team members of Kuzaa. I'm not going to be your host today because your host is right here, and I will introduce her shortly. So basically, the topic of our fireside chat today is breaking barriers, gender equity, economic empowerment, and maternal mental health. So we are going to cut across different sectors or different hot topics currently, which includes gender equity, how we can include our women into different aspects of the society, and not just including them, but ensuring fair distribution of resources generally. How we can also ensure that women are economically empowered, and also how all of this can help to address maternal mental health. So these are going to be the variety of discussions we'll be having here. And we have some interesting speakers on our Sorry, did you send something? Okay. I'm getting a bit confused with the chat room. Yeah, so we have some interesting speakers in our midst today. Without any further ado, I'm just going to introduce our moderator for today, in no other person but Miss Barbara. Just a brief introduction of Miss Barbara. She is a passionate psychologist and a mental health advocate. She has strong interest in community development, youth empowerment, and sexual and reproductive health. She also seeks to empower or advocate for women's rights and just social justice across all dimensions. She is self-motivated, detail-oriented, and dedicated to driving impact, change through innovative and inclusive programs in the various projects that she participates in. The interesting thing about today is that Ms. Barbara is not just a psychologist and a mental health advocate, but she's one of the volunteers and ambassadors of Kuzaa, just like the rest of our speakers we'll be hearing from today. Without any further ado, Ms. Barbara, you're welcome and the floor is yours. You can unmute yourself and take charge of today's event.
Okay, thank you so much.
You're welcome.
I'm Mide. Sorry for that. And
No.
Good morning, good afternoon, and good evening to everyone who has tuned in to listen to our great speakers today. And without taking much of your time, you've heard about my introduction from Mr. Ayomide. I'm also a volunteer at Kuzaa. And without taking much time, I'll just go straight to the panelists. Yeah, and our guests today are Valentina and Sabina. I don't know if they are all tuned in.
Valentina is here. I think Sabina is still trying to join, but Valentina is here.
Okay, so maybe we talk to Valentina. She can introduce herself, tell us a little bit about herself and what she does, as we wait for Sabina to join. The podium is yours, Valentina. Unmute and just tell us a little bit about yourself, and then we can proceed.
Good afternoon, everyone. Can you hear me, please?
Yes, we can.
Yes. Okay.
Yeah. I'm Valentina Honam Jamisi from Ghana. I'm also a volunteer in Kuzaa. And today, I'm a midwife and a public health nurse. And I've had 16 years experience in the Ghana Health Service. And I'm very passionate about maternal health. And today I'll be sharing my experiences with you all. Thank you.
Okay, thank you so much, Valentina. I don't know if Sabina has already joined in.
Not yet. I think we can go ahead with Valentina until Sabina is here.
Yeah, we can proceed. So the first question to the panelists, maybe they can tell us, she can tell us about the role of midwives and nurses in advancing maternal health equity, and specifically how do midwives and nurses contribute to reducing maternal mortality, especially in marginalized communities? Maybe in just a nutshell, you can tell us about this, Valentina. How do midwives and nurses contribute to reducing maternal health mortality, especially in marginalized communities?
Oh, thank you so much, Madam Barbara. In Ghana, midwives and nurses play a vital role in reducing maternal mortality. For instance, you look at the introduction of the community-based health planning and services, that is the CHIPS program, has deployed midwives and nurses to rural communities where most midwives and nurses have been posted to the various rural communities, providing antenatal and postnatal care there. I recall a story of a pregnant woman in the Western region where I was working before. During that time, this woman came to deliver with bleeding profusely. And then because of the CHIPS compound, the midwife in charge there provided intervention, timely intervention, saving the life of the mother and that of the baby. You cannot, and midwives are very trained in Ghana here. And we are the first point in contact when a woman or a pregnant woman visits the facility. And what we are trained such that when we are able to identify emergency cases, when a woman is in crisis, midwives in Ghana are able to be the first person to detect that, which we refer to the medical doctor for further investigations. To build on this, midwives have been playing a very vital role in Ghana.
Thank you so much, Valentina. Or you're still continuing? Are you there, Valentina?
Hello, can you hear me?
Yeah,
Hello.
I was asking if you are done or you are still going on.
I am done with that point, please.
Okay, that's such a great insight from you, especially that you are in the midwife. You are a midwife in Ghana, and that you understand the challenges that most of these pregnant women go through, especially in marginalized community. And I appreciate the fact that you're talking from an experience. You're talking from experience. You've been able to deal with such cases, and I really want to commend you for that. And I think we can proceed, since Sabina is not yet here with us. We can proceed to the next question for you, Valentina. How can healthcare institutions and government better support midwives and nurses in advancing maternal health equality? We understand that the government and other institutions play a hand in supporting and managing the healthcare institutions in different countries. So how do you think the government institutions can better support midwives and nurses in advancing maternal health equity?
Thank you so much. In Ghana, government and policy makers can establish financial safety nets by implementing policies like the Livelihood Empowerment Against Poverty, which is a LEAP program that's many women that are suffering with financial crisis. This LEAP program helps them, assist them financially. To build on this, we could also exploit various innovative ideas like mobile money platforms for cash transfers for these mothers. And they can also help in microfinance schemes for women's economic empowerment. They can also, I think governments should also help these mothers, empower them by giving them skills, training, so that these mothers can equip themselves. There's a case I'm working on right now, which is a mother who is having living with HIV, who is financially handicapped. Due to that, when she got pregnant again, she defaulted going to the hospital for medications. And because of this lack of financial empowerment, she's not been able to access the facility and she has transferred the infection to the baby. Right now, the baby is on admission, critically ill and need an assistance. So I think that if government could equip those women, especially those who are in their house, to learn vocational trainings like sewing, beading, but something that they can be empowered so that they'll be able to fend for themselves. I think this would help women in Ghana.
Okay, thank you so much. You've broadly talked about how government can help these midwives and nurses. How about the healthcare institutions? What do you think are the best support or practices that the healthcare institutions can provide to midwives and nurses in advancing for maternal health equity?
I think government should and policymakers can collaborate with midwives and nurses by engaging us in policy development. To take this further, we could also explore, there could be a platform where during this the policy development, they invite midwives and nurses so that we can also help. You know, we are with the mothers underground, so we know most of them, their needs. So when we are part of this, we could be able to channel their voices to government so that government can help them incorporate this into their policies so that it can fit our mothers. Governments can also co-design workshops for policy development, citizens engagement platforms and feedback, and also data analysis for evidence-based policy. You know, when all these are put in place, I think this will help a lot. These innovations can enhance the inclusivity and effectiveness of maternal healthcare policies.
Okay, thank you so much, Valentina. You've greatly tackled that issue. And what do you think, like maybe in just briefly, what do you think are the challenges that midwives and nurses face in ensuring that there's equitable maternal health care in these facilities? What are some of the challenges that you as a midwife have faced, and what are some of the challenges that you think some of the nurses in the facilities are facing? Because you're speaking from experience. Yeah, so tell us some of the challenges that you think you people are facing and in advancing for maternal health care.
Yeah, as for the challenges, we have a whole lot of challenges as midwives in Ghana here. One challenge is the human resource. You know, we don't have a lot of staff. Looking at the the midwife patient ratio, we don't have a lot of staffs that could help so that we could tackle this pregnant women one-on-one, because we have a shortage of staffs. And we also have infrastructure problem. You know, some of the places where I am working currently, we don't have space where our pregnant women can come and feel comfortably to receive treatments. We don't have that. And we also don't have certain equipment which we could use on them in case of emergency. And we also have a lot of medication problems. So all this puts in place, these are some of the challenges. And then we need, I think the way forward, and we need a lot of training as midwives, especially as nursing is dynamic, things are changing. I think to be equivalent with the international markets, we think that midwives should be given opportunity to advance in academia. Like they should give us the opportunity to go to school, to learn more things, to be advanced, what is happening in the outside world, so that we midwives will also have the first-hand knowledge when it comes to the care of pregnant women. we should also have like we don't have a form of like training. We should be having training here and there, refresher training, so that we'll be equipped with everyday knowledge, which could help in maternal health.
Thank you so much, Valentina. And it seems that there's a lot of so many challenges that indeed your field is going through. And I hope that through this fireside chat, we can also come up with ways of how to to be involved, like you nurses and midwives, to be involved in the policy decision making tables and even in the policy making tables. So over to the next question. How has technology changed the way midwives and nurses provide care, particularly in remote areas? What is your thought about this? How has technology changed the way midwives and nurses provide care, particularly in remote areas?
Please, can you come again, please?
Oh, sorry. How has technology changed the way midwives and nurses provide care, particularly in remote areas? We understand that we are moving from an analog-based world. We are all moving to the digital-based world. So how do you think the evolution of technology has changed the way midwives and nurses provide care, particularly in remote areas? Because we all understand that most of these remote areas, they lag behind in technology and everything. So how do you think technology has changed the way midwives and nurses provide care, particularly in those remote areas?
Okay, in Ghana, where technology has revolutionized the way midwives and nurses provide care. For instance, the mobile technology for community health, that is the MOTEC initiative, uses mobile phones to provide antenatal and postnatal care to pregnant women in rural areas. With this, you could see technology now, people in the rural areas now also have access to social media, whereby, like example, what we are doing now, people in the rural areas, some of them are using smartphones now. So most of the times when those webinars are held, some people have the chance to read more on that. Some people have like this chat GTP. Some people are using it because surprise you, a mother comes from the rural area, is holding a smartphone, and whatever you say, she Google and find out what you are saying as yeah. And then I think this technology has helped. Especially there is also the MOTEC, somebody can just, whatever that is wrong, the person will just type in something and then the person will receive an answer. And I could also take this, that we could also explore innovation ideas like artificial intelligence, powered chatbots for health education, and probably the drone delivery of medical supplies to rural areas, and the virtual reality training for midwives and nurses. I say it again, midwives in the rural areas should also be empowered, or they should be given some sort of television. You know, some remote areas in Ghana may not even have access to electricity. So with this, I think that it's really a problem, and technology too has done a lot and is helping people, especially midwives. So that is what I have to say about it.
Okay, thank you so much, Valentina. I love how you are speaking about the issue of technology so passionately, because you as an expert in that area, you know how technology has influenced the remote areas, because you're talking about the remote areas in Ghana not having access to electricity and so on. So I just love the fact that you're so passionate about these about midwifery and nursing, and also about the maternal health care, the equity in maternal health care. So how can government and policymakers create financial safety nets to support women during and after pregnancy? How do you think that government and these policymakers, these people who are seated in the policy making table, how do you think they can create that the aspect of financial safety to support women during and after pregnancy? Because we know that most women who are in who are maybe pregnant or even after the pregnancy period, there is that financial strain. So how do you think the government and policymakers can create financial safety nets to support women during and after pregnancy?
As I said it earlier on, that we have something in Ghana called the LEAP program, whereby women that are facing severe financial crisis are being sent some mobile money cash. And then they should also equip them, the mothers, with skill. You know, when you have skill, when you are empowered, you have a job, you learn a trade, at least you can be doing something to cater for yourself than to depend on somebody. So I think that when these mothers are empowered, especially those who have not been to school, they should find a sort of work, something like skill training, and then the social welfare too should come in place so that they can assist mothers like this, so that they are financial. And there is something we teach them, we call it bed preparedness. Once you get pregnant as a woman, you should start saving something, whatever that you have. With a 9-month journey, because we made something a susu box. We call it susu box, where we always educate them. Once you get pregnant, you put that box somewhere, and whatever that you have, any gifts you have anywhere, you go and put it in that box, so that in terms of financial crisis or you need medical attention, that you need to fall on finance on something, you go into your box and take that. And they should also provide assistance, NGOs and non-governmental agencies in the community too, or support groups can also come in to help educate these women so that they can be empowered financially. Thank you.
Okay, thank you so much, Valentina. I've seen one of our speakers has joined, Sabina, and I'll just give you some few minutes or rather seconds to introduce yourself, to tell us about yourself, and maybe we can proceed from there. Sabina, you can unmute yourself and tell us who Sabina is and what Sabina does. Thank you.
Thank you very much, Ms. Barbara. I'm sorry for coming in late. My name is Sabina Fafa-Ketomanya, and I'm a registered midwife with 8 years of working experience. And I'm happy to be a volunteer for Kuzaa. And I would like to acknowledge the team and the CEO and everyone. I'm very happy to be part of the speakers this afternoon. Thank you very much.
Thank you so much, Ms. Sabina. And I guess you can proceed from here. Maybe you can share examples of innovative approaches midwives and nurses have introduced to improve maternal health outcomes. From the experience that you've had in all these years, you can share with us the examples of innovative approaches midwives and nurses have introduced to improve maternal health outcomes.
Okay, thank you, Ms. Barbara. And over the years, midwives and nurses have been implementing innovative approaches to improve maternal health outcomes. And it's particularly done in the underserved areas. And some of the approaches include digital technology. With remote monitoring and communication, we are now using information centers as a source of information, as a source of communication to our clients. I've had the opportunity to work in most of the remote areas within the whole municipality. And the first place I had the opportunity to work, there's an information center or a place where you can go to disseminate information. So we held our health talks, our education, and anytime we have CWC or child welfare clinic, we have antenatal, we see the opportunity to use the information center to disseminate information to our clients. And then in this day and age, there's also personalized care. That is, midwives are able to give their phone numbers to clients and their families. So it makes it more convenient for midwives to disseminate information to clients. The new maternal health record book we have, it has a place where midwives can just put their telephone numbers. So sometimes when clients are having problems, they don't necessarily have to come to the health facility. It is just a matter of calling and then their problem is solved. Then also we have community-based interventions. If you are working in the marginalized communities or the rural areas, it is good you engage the community with planning and implementation of maternal health programs. And this can help you to come out with better outcomes. You have to involve significant others in the care of the pregnant woman. We also go for community outreach programs. And this has helped a lot. When I was first working in 2016, there were communities around the health center where I worked, but due to barriers, they couldn't access the healthcare. I had to sit on motorbike for like 30 minutes while I was pregnant myself, just to deliver care to them, because I was alone in the facility and clients were in their villages or their communities not being able to access healthcare. So I took it upon myself to go for home outreach programs to render service to them. And this has gone a long way to help us. There's also enhanced workforce, that is continuity of care. Gone were the days where midwives deliver for clients, they take care of them through pregnancy, childbirth, and that is it. In this day and age, we hand them over to the CHN, that is the community health nurses at the reproductive and child welfare unit. So the care is a continuous one now. We don't just look after them through pregnancy and then that is the end of it after delivery. We make sure we hand them over for care to be continued, for baby to also be in good health. Thank you very much.
Thank you so much, Sabina, and I'm so glad that you've touched about the technology, because Valentina has also shared about how technology has improved and how technology has helped to improve the maternal area. And I'm also glad that you're also talking from a point of experience about you've talked about the maternal health care book having the phone numbers, and that is something that also Valentina had touched a little bit about, but we are glad that you've at least expounded it, and you've also spoken from the experiences that you've had. So thank you so much. Okay, maybe you can tell us what are the biggest financial challenges that pregnant women and new mothers face, especially in marginalized communities.
All right, thank you. So pregnant women and new mothers face so much financial challenges in marginalized communities. And being one midwife who has worked in these communities, I've had the experience to see how the people are being affected by their financial challenges. So the first thing I'll talk about is access to healthcare, the cost of prenatal care. Most of the women in the marginalized communities struggle to afford cost of antenatal care. That includes transportation to the clinics, fees for consultation and medications. And I had a woman who came for admission recently, and she had gone for ANC, antenatal care, for only twice. And she was at term, that is 9 months of pregnancy, but she attended antenatal only twice. And through history taking, I got to realize she didn't have money to take car from her home to the health facility. So she was able to attend only twice because of financial problem. So if she had the means, she would have been able to attend antenatal throughout her pregnancy. Then we also have cost of delivery and postnatal care. It's funny to know that in this day and age where maternal health is supposed to be free, the expenses associated with childbirth, including hospital stay, medical procedures, and postpartum care can be very, very significant a burden on them. And this lacks access for affordable or free healthcare service to their clients, in the sense that sometimes they are not able to afford the procedures they are supposed to undergo. A typical example is a woman we had who came with post date, and she was booked for cesarean section. When they mentioned the average estimated amount of money she would pay, she would rather stay to deliver on her own because she didn't have the money. And we had to try to convince her because the pregnancy was overdue. The time was overdue. It was post-date, and we needed to bring the baby out through cesarean section. But because of the financial problem, she didn't want to, and we had to intervene through social welfare and others. So this is a big financial challenge on them. Then most of our clients lack insurance. Sometimes it is due to the insurance offices or where the services will be provided being far away from them. So they do not have the means of transport to go to the insurance centers to get these services. So they do not have money. Since there's no insurance, they don't have money to also access healthcare. And this further exacerbates the financial burden of accessing healthcare on them. Then also, there's also these nutritional needs, which is a cost which is being caused by financial challenge, because most of them have problem with money, so they are not able to afford nutritious diets, and they come to the facility with anemia most often. Most of their children too are malnourished. If they have the finances, they would be able to get the nutritious diet, the adequate ingredients to use, the vegetables, the fruits, and all that they need to boost their immune system. But because the finances are not there, they are not able to get adequate diet. And then we also have socioeconomic factors. Example is the gender inequality. This can lead to women having less control over resources and decision-making, further limiting their ability to address their financial needs. There was an incident recently in the Oti region where a teacher who we should all know is a literate and knowledgeable died with her pregnancy. And this happened because she was waiting for her husband to return before she could come to the hospital. She didn't have control over that decision making. She couldn't decide on her own to come to the hospital. She had to wait for her husband, and this is a big challenge. At the end of the day, she died before they even got to the hospital. And then also we have challenge with housing and living conditions. Many marginalized communities have inadequate housing conditions. These include overcrowded living spaces, the health of the pregnant station. We do have people coming in with all sorts of infections and waterborne diseases because they do not have to get water from wells, from rivers, which are not hygienic. So at the end of the day, these clients come back with all sorts of diseases and infections, with a lot of risk and dangers on their health. So these are some of the financial challenges our pregnant women and new mothers go through in the marginalized community.
Okay, thank you so much, Sabina. It's so unfortunate that even after even in an age and in such a century that we're living, that women have to still depend on their husbands to make such a vital decision. So I really appreciate you sharing such those insights. And because some of these things that are happening, the policymakers are always involved. So to maybe Valentina can tell us, how can government and policymakers work with midwives and nurses to create a more inclusive maternal health care policies? Valentina, if you're trying to speak, you're on mute. Kindly unmute.
Okay, thank you so much. I strongly believe that if Ghana government and policymakers can collaborate with us, nurses and midwives, by engaging us in policy development, this could go a long way to help our maternal health, in a sense that when they open platforms for us, when they are going to have a conversation around this, I think that midwives and nurses should be invited so that we'll be parts of this program, because as nurses and midwives, we are the frontline person that when the clients visit the facility, we are the first point of contact. So we are able to, because of the nature of our work, we are able to detect their problems and identify their needs. So when we are part of this policy decision making, we can also bring the voices of our mothers, those who are in the rural areas, those who are in the urban areas. We can channel all their concerns to policy makers. And when they could, if data, the policymakers take data analysis on evidence-based evidence-based, so that these could also help develop policies for our mothers. It will go a very long way. Thank you.
Thank you so much, Valentina, for such great insights. And maybe Sabina can share with us what are the key policy gaps that hinders progress in maternal health equity.
Okay, thank you, Ms. Barbara. So there are a lot of policy gaps that hinders progress in maternal equity. And the first I will talk about is financial barriers. And that is high cost of maternal health care services, medications, and all the other things their clients need. And this can create significant financial barriers, especially for low-income individuals and families. It's rather unfortunate in this part of the world. Those in the rural communities have a lot of financial challenges, and most of them are unemployed and rely on just meager salaries or farming activities, but they have to access the same healthcare with those in the urban areas who have access to good quality care and those who have the money to pay for. So I think this is a disparity in access and quality of healthcare, because those who are in the rural areas, they do not even have the health facilities. There is a town I know where the health facility, before you get there, you have to cross 2 rivers. You have to cross 2 rivers before you get to the health facility. So if you do not have the means, you cannot cross, you cannot go. You don't have the financial means to cross. And this is unfair to those living in the rural areas, which is a big gap that should be looked at. There's also lack of cultural competency training among healthcare providers, and this can lead to misunderstandings and barriers to care for individuals from diverse cultural backgrounds. I have witnessed the clients came for antenatal care, and then she had wrapped a white cloth on her abdomen. So when we wanted to do abdominal examination for her, she said, no, we shouldn't touch the white cloth, and that she would remove it herself. And we had no idea it was there for a reason. We thought it was just part of her clothing. But because we were not abreast with their cultures in that background, we didn't know. So if health workers, especially those in the rural areas, will be trained to understand some of these cultural backgrounds, then we can give good and quality care to our clients. There's also workforce challenge, that is provider shortages. Unfortunately, most of the healthcare professionals do not want to go to the villages when posted. And I would understand, because when I was posted first, the first place I worked, There was no network, there was no pipe-borne water, and then we see car once in a week. That is to say on market days. So if I have lived all my life in the city and been posted to such a community, it will be a huge task for me to accept and go there. And that is a big policy gap because those in the rural areas also deserve good quality healthcare. So all these things should be put in place for them to also be able to access this good care. And then there's lack of training and education. Insufficient training and education for healthcare providers, especially nurses and midwives, can lead to gaps in knowledge and skills, and that impacts the quality of care that we give. There are lots of people working in the rural areas who hardly have access to the CPD programs those in the cities get access to. Sometimes because of network issues, they are not able to even learn on their own or update themselves. Yeah, so it is a big gap when it comes to progress in maternal equity. Thank you.
Thank you so much for such great insights, Sabina. And I'm so glad that we are having such discussions even today. And on to your, okay, there's a question in the chat box before we move to the call to action. So Ayo is saying, I would like the speakers to share the experience with women suffering from mental health conditions and how were they able to identify the mental health conditions. So this goes to any of you, any of the speakers who can tell us about their experiences with the women suffering from mental health conditions and how they were able to identify these mental health conditions.
Okay, I would address this from experience. We recently had a client who came in labor, and everything you say, she begins to laugh. She laughs at anything, everything. And then we saw her running out all of a sudden, and she wanted to take out her clothes. Luckily for us, it was daytime, so we had the securities around. We had our obstetrician, we had the psychiatrists also around, the psychiatry nurses. So we quickly had to call them. And then after delivery, she didn't want to breastfeed the baby. She said that wasn't her baby. She wasn't pregnant and she never gave birth. So luckily for us, the signs were glaring. And it was someone who brought her to the facility, not a family. Later, we got in touch with the family and realized she had been diagnosed with depression. But unfortunately, because there was no good support system, she doesn't take her medications and she doesn't even come for her antidepressants. So during labor, she relapsed. They didn't know she had relapsed because she was fine. But I think with the labor pains and all that, she had a relapse when she came to the ward. And after delivery, she had to be put back on her medications. Yeah, so that is how we were able to identify her problem as a mental health condition and then helped her. Thank you.
I would like to add something to it. Thank you, Sabina. I would like to add something. In my area, how we handle women with mental health condition, there was an instance where a mother came to our facility and she was like 29 weeks pregnant. And when she came, whatever that you tell her, she'll just be staring at your face. So we realized that during antenatal, she always come by herself. Nobody supports her. So upon investigation, we realized that her husband has absconded and then no one was taking care of her. So we probed further and then we sent her to the refer her to the mental health nurses. So they took over. And what we do was that we're doing home visits, we're following up on her. And we realized that she doesn't have a support system. She lives alone by herself. So what do? We have to go in and look for the partner's relatives and that of her relatives. So when we went, we got some few people like her mother's side. We have a sister and then a brother. So we talked to them that they should at least let somebody be with her. So they provided her with a younger sister who was living with this woman. And what I say, unfortunately, the pregnancy did not last to term. So they have to take this mother for cesarean section where the baby was a preterm. So when this baby came out, when she saw the baby, that has even worsened the case at all. He said the baby looks like a lizard because the baby weighs 0.9 kg. So she wasn't happy, she wasn't touching. So we call it postpartum blues. She was not responding. So what we did again was that we referred this mother to the counseling unit where he was taken through several counseling sections. And then we too, as midwives and public health, we collaborated with the public health nurses and community health nurses where though these nurses work in the community. So those nurses also follow up on them. Oh, she became a friend, we're talking to her. So through her, she was taking her medication and now she's fine and baby is fine. This is how sometimes we handle such cases. Thank you.
Okay, thank you so much to both of you. And we can both acknowledge that that is so scary. And we can also acknowledge that women need that support, emotional support during their pregnancy. And okay, so there is a second question, and then we can, from the second question, we can then proceed to the call to action to both Valentina and Sabina. So the second question is, what do they think is the most significant trigger of maternal mental health? So you've talked about they lack support. So what else can you add on to that as a trigger to the maternal mental health?
Thank you so much, Barbara. Some of the challenges, some of the triggers can be financial. When they do not have, they are not empowered financially. It can also trigger them, especially when they are thinking of how to buy baby things, the diapers, the antenatal visit. As my co-speaker earlier on said, that some of them do not even have the national health insurance, and others do not even have money for transportation to visit the antenatal facility, and then maybe for various investigations to be done. These are some of the things that triggers maternal mental health. And to talk about the support, to emotional support, some of the reasons are maybe they want the gender, maybe she has given birth to all girls and the partner wants a male. Some of these things also triggers it. And then maybe probably she has, maybe unfortunately, the child is having abnormality. The child comes out with no arms or one leg, and then these are some of the things that triggers them, or the child is born prematurely. These are some of the things that triggers maternal mental health. Thank you, Barbara.
All right, thank you, Valentina. To add to that, mostly with pregnancy and postpartum, it involves hormones. And then when there's hormonal fluctuations, it poses a trigger on the mental health of the client. So that can be a cause, hormonal fluctuations. Then if clients have family history or personal history of previous mental health problems, like the client I spoke about, this woman is at risk of developing mental health problem again later in life. And then also, I have encountered clients who use substances and alcohol. So if you are using alcohol or other substances, it can contribute or worsen mental health conditions during pregnancy and postpartum period. And then there's also challenges of caring for the baby. Most of the clients in the rural communities, because of their farming activities and all that, they do not get support when it comes to caring for the clients. So adjusting to parenthood and then struggling with their work and other things poses their mental health to this kind of conditions. And we can also talk about obstetric histories. Past obstetric history and unplanned or unwanted pregnancies can also contribute to maternal mental health issues. We had a teenager who came in labor. She said she didn't want to get pregnant, but unfortunately, she had had lots of abortions, and the one she came with at term, she couldn't abort it. But after delivery, she didn't want the baby. She didn't want the baby. She didn't want to breastfeed. She didn't want to have anything to do with the baby. And that transition really affected her mental health. Personally, she couldn't take care of herself and she couldn't take care of the baby. And we had to put her on medication, refer her and all that. So I think these are some of the significant triggers to maternal mental health. Thank you.
Okay, thank you so much to both of you. And I know that we have a lot to unpack in this topic, and we are eating into our audience time. So maybe you can just briefly a call to action. What can be your last call to action, Sabina?
Hello, Miss Barbara, please come again.
I'm saying, what can be your call to action as we wrap up this conversation today? What can be your call to action?
Okay, thank you. So I think for us to, as midwives and nurses, to be able to give adequate and quality care to our clients, regulatory bodies should ensure that our hospitals and facility health centers are equipped with supplies and commodities we need as health workers to work with, because there's even a shortage of just vitamin K in a facility right now. And after delivery, the client had to go to pharmacy or another town to buy vitamin K, which is an important drug we use. And also there's another facility where there's no oxytocin and there's no cytotec. So in times of obstetric emergency like postpartum hemorrhage, the midwife and the clients are both at risk, because by the time you refer this client to a higher facility, the delays can be so there. So I think the regulatory bodies should ensure, and the hospitals should also make sure they have commodities in place for midwives and nurses to work with. And then also midwives and nurses should be trained on the job. They should organize workshops, in-service trainings for us to up our knowledge and then skills. And also, I think being someone who has worked in the rural area and the urban community, I think there should be a platform where those in the rural communities can communicate easily with those in the higher facilities, because sometimes you would want to refer a case, but you do not have that communication, that channel is broken. So at the end of the day, it causes a lot of delays. And sometimes you can just communicate with a specialist and you are told what to do, and it can save the client much earlier than referring this particular client. And I think also that midwives and nurses should be supported and compensated. Sometimes the trauma we go through when it comes to certain conditions we manage, it is not easy for us. So I think midwives and nurses especially, they can recommend clinical psychologists for us, because we go home with so much trauma. Sometimes it affects us. And then when it comes to the equipment we work with, right now there's a facility where the delivery bed is so bad that the midwives, most of them are having waist and spinal problems, because the delivery bed is not adjustable. You can't adjust it to your level. You have to bend and offer that service to the client. So by the time you do 2, 3 deliveries, you are exhausted, and this has a toll on us and our families, because you come home tired, you come home with pains, and even we have issues in our marriages because of this kind of problems. If you're having waist pain, you can't deliver well for your husband to see the power in you, you know. So that was just by the way. So we have a lot of problems when it comes to this. And then I think regulations should be put in place so that some of these things will not affect us, because it is said that the nurse is the heart of the hospital. So if we are in good condition ourselves, psychologically, emotionally, we are stable, we'll be able to deliver to our clients. Thank you very much.
Thank you so much, Mrs. Sabina, for that. Valentina, you can wrap it up for us, just a small parting shot. And which is your call to action.
Okay, thank you so much, Barbara. I think individuals and communities can also come together to advocate for maternal healthcare policies by supporting organizations like the Ghana Registered Nurses and Midwives Association and the Coalition of NGOs in Ghana. To help build this, we could explore various ideas or innovative ideas like engaging community leaders and stakeholders so that they can come together to advocate for maternal health. Then we should also increase our social media campaigns to create awareness and advocacy, since now technology is everywhere, and also community-based advocacy groups for policy change. And then we can also collaborate with partners, with private sector companies for resource mobilization. And I always tell every woman out there, please, once you realize that you've missed your period or you've not seen your monthly flow, quickly report to the health facility so that we can have your baseline information, so that when something is happening to you, you know which one is normal with you and which one is not normal with you, so that action can be also taken. We also treat or plead with government that whenever they are making policies for the Ghanaian women, they should also collaborate with nurses and midwives so that we can also have a say in that policy or that decision making. And they should also provide us with resources and then infrastructure. They should also motivate us. We need motivation because the burnout is too much, because we have inadequate staff, and a midwife alone could look over 10 patients or 5 patients. Or antenatal service, see one midwife alone in the cubicle looking after over 50, which we want the quality. If you want quality healthcare, we need a lot of staffs so that we could also enhance quality care. We want them to also give us trainings. You know, we need to know, we need to have knowledge in so many things. So the new things that are happening, we need to shower our levels with the international world so that when we have the knowledge, wherever that we find ourselves, we could be able to provide a well or a quality service to our women. And also entreat women that please and please, you can also help yourself. When you get pregnant, I'm saying it again, don't live at home. They have a belief that when they get pregnant, they have to stay for 3 or 5 months before they come to the hospital because they are afraid that bad eyes will make them have miscarriage. No, please come. Nurses and midwives at the facility are not evil. We are there for you. We are your friends. So please come to the facility. And then don't be afraid to open up and share whatever they are going through. Find somebody trusted and share your belief with all these things. I think we will have, the future will be bright for maternal health. Thank you so much.
Thank you so much for the very powerful insights, Valentina. And I really appreciate you taking your time. I really appreciate the audience for being here today. And we are so sorry you have eaten into 12 minutes into your time. Thank you. Thank you very much to the panel and to the host. Ayomide, back to you.
Wow. This was powerful, and indeed short for words or short of words to say. I think our speakers, our moderator, all deserve a big round of applause for the insightful sharing, the very important questions. I really like the fact that our speakers actually use their personal work experiences to actually deliver the speech. It makes it very understandable and relatable. So without taking too much of your time, we just want to say thank you once again to the speakers on behalf of Kuzaa. And also thank you to all the participants who joined this fireside chat today. Without you, this would not be happening. We just want to wish you a very nice day. Enjoy the rest of your day. If it's in the evening, wherever you are, have a good evening and a good night. And if you're still at work, enjoy the rest of your day at work. From all of us at Kuzaa, we say bye-bye.
Picture, please, Ayo.
Oh, okay. So please, if you can, kindly turn on your camera. Let's have a group picture about for today's activity. Tell me, how many seconds are we supposed to wait? So just keep smiling. Success, please let us know once you have taken the picture or when we should pause. Success, our smile is finishing. Are we okay?
Success is not in the meeting, so I'll take the picture.
Yeah, okay.
One more. Smile very well.
Okay.
Done. Thank you so much.
All right, everybody. Bye-bye.
Bye. Hope to see you next time. Bye.
See you next time.